Okay, so we're ready for some questions. Anybody have any questions from the audience? Yes.
Okay, so my question is, if 60% of thyroid cancer tumors are caused by BRAF, and many of those tumors are resistant to picking up the radioactive iodine, why did radioactive iodine become a standard of care for thyroid cancer?
Well, that's a very good question. I mean, I think the fact of the matter is that we now are revising, to a certain extent, our idea of the value of radioactive iodine. For many of the very small tumors, very small papillary thyroid cancers that have had very good surgery done, historically we would treat them with radioactive iodine as well because it was given essentially to everybody. Okay? It's likely that many of those patients would have done just as well without the radioactive iodine. So now there's a large number of patients that we've decided not to give the radioactive iodine at all if they have relatively small tumors, or they don't have much in the way of lymph nodes involved. We're still not at the point that we say, if you have a BRAF mutation, you shouldn't receive it. And the reason, if you remember that slide I showed, there's about a 20%, 25% of patients with BRAF tumors that actually preserve the wherewithal to trap iodine. We think that in the next 2 or 3 years, based on these molecular panels that we are now putting together, that we should be able to distinguish a priori which patient with a BRAF mutation probably shouldn't receive it at all, if we can confirm what the TCGA program showed.
I'd also say that part of the reason that it was used is that some patients really got great responses. And we don't know exactly why, but some patients do preserve their ability to take up radioactive iodine. And I think if you remember that case I showed with I-124 that we followed over multiple doses, that was really done over a prolonged period of time, over 8 years or so, and he never lost the ability to take it up. And I think I have a number of patients like that who he would have died of his disease, undoubtedly, if he hadn't been treated with radioactive iodine. So, and the other thing is that we have partial responders of people who have some uptake and then they appear to have stable disease. It appears as though it's a dose-related phenomenon, and there may be intermediate grades of NIS, or the sodium iodide symporter, which are expressed by relatively low doses of, let's say, the gene. So, but what all of us agree on is that it's absolutely going to revolutionize our treatment planning to have this kind of genetic testing, which we can then correlate with outcome. And that's what we must do. We must really be aggressive now in pursuing this so that we'll know what exactly we're
the other thing I would add, I think, was I agree with you, Steve. I mean, it turns out that many of the patients that have these RAS mutations and these receptor tyrosine kinase mutations that had the red, those are the ones that did preserve the activity, are actually the ones that sometimes go to the lung. Okay, so many patients that do have small lung metastases end up having RAS mutant tumors, and those respond, quite well. So and remember, I mean, we were not in a position, for the first 50 years of the use of radioactive iodine of being able to make any of these types of distinctions, right? So this is now just really happening, and it's going to be refined. But I agree with what Steve's saying. There's a real place for radioactive iodine for a significant fraction of patients.
So, Jim, I wanted to ask you a question, and then we'll take another question. And that is the relationship. We've heard from, every guideline has age in it. So one question is, what we notice is that young patients have a very high response rate to radioactive iodine. Mm-hmm. They take it up well, they respond well. These are patients less than 21 usually. Can you make any comment about the alterations in the genetics that occurs as a function of age?
Yeah. So 2 things. First of all, in young patients, BRAF mutations are infrequent. Okay, so we have looked at this and published on this a number of years ago, whereas in the adult population, you've seen it's 50-60%. In children, it's more like 10 to 15%. What they tend to have are these receptor tyrosine kinase fusions dominantly, and those respond better to radioactive iodine. The second piece is that one of the things that this Cancer Genome Atlas data showed is that there's a continuous effect of age on the mutation burden of the cancers. So we've known for a long time that if you're unlucky enough to get a thyroid cancer and you're quite old, that you probably have a chance that that disease will be not as benign, let's put it that way, or more aggressive than if you get it as a young individual. And those tumors are associated with a higher mutation burden. And as opposed to being a sharp distinction, because we classify them as younger than 45 or older than 45, it's actually a continuous effect. The older you are, the more likely you are to have a tumor that has a lot of genetic changes. The more genetic changes, the more likely you're going to have a problem.
Did someone have a question back there? Yeah.
Do you think that alcohol ablation will be an option in the future for not just lymph nodes but actual small cancerous nodules?
It's a good question. So I'll repeat it again, just in case the microphone didn't work well. The question is there a role for ethanol ablation of either small thyroid cancers, primaries, or small lymph nodes that we don't want to operate? And there are institutions like Mayo Clinic that have been doing this routinely now for a number of years. It's in good hands. It's a safe approach. They have not seen much in the way of negative effects of doing this. So that would be encouraging. The reason that we've not implemented at our institution is that we believe that I was here towards the end of the morning presentation and heard Dr. Shah saying if you have a small lymph node, even if it is a cancer and it's really tiny, it's probably never going to cause you a problem. It's unlikely to cause you a problem, particularly if it's stable over a follow-up. So we've taken the philosophical approach is if it's not doing any harm, we probably don't need to intervene and do anything because we're not changing the outcome of the disease. The Mayo Clinic people accept the fact that when they do the ethanol ablation, they're not doing it because they're going to improve outcomes. They agree with us. Outcomes are just as good if you leave that lymph node alone or if you leave that very tiny thyroid cancer and don't treat it, okay? But they do it because they feel patients are more comfortable with the idea that they've eliminated a site of disease. So I would say it's psychotherapy as opposed to medical therapy. It probably is a little extreme way of putting it, but I think in the gist of it is that way. I mean, if there is a disease significant enough, okay, that it truly requires and needs to be removed, surgery is a better way to do it because you can get compartmental resections and you can really try and make sure that the disease will not come back there. Okay, ethanol ablation is essentially just berry picking things that are a little large and so on. Has a place, but in the setting of what I just mentioned.
So, Amy, are there any questions from the network?
Yes, so we have a few questions. Hopefully you can hear me. Specific to BRAF, there was a lot of conversation within our Facebook group. Someone wanted to know whether if they do have a BRAF possibility, does that mean they're going to definitely have reoccurrence in their lifetime if they've taken care of it?
No. So I think it's an important thing to reassure people that BRAF was a really important oncogene that was discovered in this disease and found to be very highly prevalent. When you look at large patient population series and you have a BRAF mutation, you're slightly more likely to have lymph nodes involved at the time of surgery, slightly more likely or more likely to not respond as well to radioactive iodine. But remember, we have about 60,000 new cases of thyroid cancers every year. 60% of those have BRAF mutations. And the mortality from this disease has not changed in the past 20 or 30 years. Okay? It remains extremely low. It's in the order of about 3 or 4%. So if 60% have BRAF mutations and mortality is 3 or 4%, it tells you the majority of patients with BRAF mutations do just fine. Surgery is curative for many of them. And when it is not, even if you have a BRAF mutation and a lymph node is present, in most cases, those lymph nodes don't tend to grow. Okay, they remain stable. We now know of other mutations associated with BRAF that when you have both together, they select for the patients that really have more of a problem. But having a BRAF mutation by itself shouldn't make people too concerned, because it's the majority of people with this disease, and as I said, most people do very well.
Okay. Another question is related to breast cancer, and is if there's any proven connectivity between thyroid cancer and breast cancer or other related cancers.
So when you look at large registry databases, like, some countries keep these very good cancer registries, there is sometimes a significant association seen between thyroid cancer and other types of cancers, breast being one of them. It's a very weak association. But we cannot assume that this is meaningful, because remember, when an individual enters the medical system, okay, and you start seeing a doctor, it's much more likely that you're going to get all of the appropriate sort of surveillance studies that need to be done. Your mammograms will be done on time. Somebody will actually feel your neck, and so on. And so you begin to see associations that may be spurious. There is no genetic basis that connects both diseases. Okay, so there's no susceptibility gene for thyroid cancer that basically is also present in breast cancer. So I would say that association, yes, there are some statistical sort of data, piece of data that connect an increased relative risk of breast cancer if you have thyroid cancer and vice versa, but it's a very weak association, and it could just simply be, due to this fact that when you enter the medical system, you're going to be diagnosed with more conditions.
Okay.
Okay?
And we have one more question related to.
And then we'll take your
No.
question after this.
Okay. Just related to thyroid cancer, quality of life, and iodine. I think this question goes back to what Dr. Green was talking about presence of iodine in our daily diets, whether we have thyroid cancer or not, or post-thyroid cancer. Where does iodine fit into the daily diet? Should we be eating more of it? Should we be seeking it out? How does that work?
I think there's no reason to, we should have a totally normal, balanced diet. The normal American diet is iodine sufficient. It's about, it gets periodically monitored. But people who have had thyroid cancer don't need iodine supplements and don't need to avoid iodine. It's essentially a non-factor. Steve, would you agree with that?
Yeah, no, I agree.
Just have a quick question. So I think a lot has been learned in the past couple of years about radioactive iodine treatment, who should be receiving it. But what I would say is, like, if you have received your first dose, potentially at Sloan Kettering, would you know after the first time that a patient receives it, like how well they would do potentially in a second time? So that's after the first dose that they receive it.
So the great majority of patients that do receive radioactive iodine just receive a single dose. Okay, and the way we monitor the response, because by and large, when we give it in two ways. I think this may have been discussed before. One is because even though we don't have any evidence that there's still disease left behind, we're trying to prevent it from coming back, or we're trying to unmask many small sites that we may not have seen up front. That's called adjuvant radioactive iodine therapy. When we do that, and after a scan is done after you receive the dose, that provides important information because it tells you whether there's any abnormal region that has trapped the iodine. And if there is, then we monitor those sites to try and see there's nothing structurally abnormal present, and that allows us to also monitor the response to therapy. Subsequent to that, in the past, we would quite routinely do a second scan with radioactive iodine. I would say by and large, in some cases where we are just giving it in the adjuvant setting in a relatively low dose, if there's not been any abnormal site of uptake, if the thyroglobulin is undetectable, and we see no structural recurrence of the disease over time, we probably don't repeat the scan again. Okay, but it's different, of course, if there's evidence of structural disease. In those cases, yes, we would repeat the iodine scan to see if another treatment dose would be beneficial.
One of the things we do to follow whether these treatments are effective is to use a variety of parameters. The imaging itself to look at whether there's shrinkage. We also look at thyroglobulin. Thyroglobulin has been a very helpful marker of total disease burden, and so we often monitor that. And if it looks like we're getting a response, and we think that there still are metastasis in critical areas, then we will treat. Then we may repeat the dosing. As long as it's effective, we often will repeat the dosing, although we are mindful that there is an increasing risk, especially above 1,000 millicuries or so, of other unpleasant side effects, including blood dyscrasias and even leukemia. But those are pretty uncommon, and we've rarely observed them here, although it's not been uncommon. I've had one patient that I know of for sure who likely had leukemia related to high-dose radioactive iodine therapy. So it's a balance of risks always, but we do monitor and make sure that we're getting effect from the iodine. Remember that although 60% are BRAF, there's also 40% who are in the other group. So there will be a group that does respond to radioactive iodine, even in adults.
Thanks.
Hey, one quick question. What are like the nutritional guidelines for patients who have thyroid cancer or maybe thyroid abnormalities when it comes to soy?
When it comes to?
Soy, like soy products?
So yeah, the question is about, we don't necessarily sort of advise people. Why do you ask specifically about soy?
Because I just read that it could feed into different thyroid like hormones when it comes to soy. So I didn't know if there's some consensus among endos or anybody, and like any recommendations that you give to your patients. And I'm also a dietitian, so I was just curious.
Well, I mean, once when patients are being prepared to receive radioactive iodine, we prescribe a very strict iodine sort of free diet. We need to do that in order to maximize the response to the therapeutic dose of radioactive iodine the patient will receive. After that, we provide no particular nutritional sort of limitations. People should be on a totally normal diet with no concerns whatsoever. They can eat as they did previously.
Thank you.
Anything more, Amy, from the web, or should we?
I think we can wrap it up. We have some specific questions we can ask offline. So thank you to everyone who's been tuning in for your questions.
Okay.
Absolutely, and thanks everyone for questions. Did everybody get a chance to answer their question? I think you had a question that wasn't answered in the first session. Did you? Do you want to ask it? Okay, great.
Thank you.
Okay, thanks a lot. So with that, I'll introduce Joan Shea, the president of Light of Life Foundation.
Well, I would like to close out by first thanking the physicians today. Your presentations were amazing. I think you provided us with wonderful information and certainly new material. It comes to mind to me that it's not an exact science, but it's amazing to me how it has really, really changed through the course of my 20 years, and particularly over the last couple of years. I'm proud to say that the physicians today here speaking have made tremendous contributions to these changes. So I'd like to thank you, and I'm honored to have you here to present this material to us. What I'd like to leave the patients with is, I've learned that no two patients are the same. Our treatments, as you've learned today, are individual. And through all these new tests and treatments and following us and pathology, the pathology, it's almost like we're having targeted therapy, so to speak, individual targeted therapy. And so with that, I am confident and I feel reassured today that most of us living with thyroid cancer, such as myself, will continue to do well. So my hands go out to you, and thank you. I also am thrilled that we were able to do this live stream. I hope that the patients who were able to watch today were from their homes, were also helped and given support. And please feel free to visit us at our website at checkyourneck.com. And if there's anything we can help support you with, we would like to do so. We would also like to thank our sponsors today. We've had a great amount of sponsorship from the pharmaceuticals that have now come into play in the thyroid cancer world, and that's Interpace, MPS Pharmaceutical, Veracyte, Bayer, AstraZeneca, Genzyme, and Eisai. So I thank you very much for your support. So with that, I close out the day, and hopefully we'll be together next year at another conference. Thank you.